we're going to be introducing our first speaker, and that will be about minimizing blood loss in cancer surgery for better outcomes. And our speaker is going to be Dr. Christopher Simutowe. And just wanted to let you know that his bio is very impressive. I'm going to go ahead and read that. So Christopher Simutowe has a lot of initials after his name. FRCSI is one of them, FRCSEd. But really the background for him is extensive, and it says that Dr. Christopher Simutowe, his journey in medicine began with his foundational education in the University of Zambia, where he earned his Bachelor's of Science in Human Biology and later his Bachelor of Medicine and Surgery, which is MBCHB. His postgraduate studies at the esteemed Royal College of Surgeons in Ireland earned him the title of FRCSI, which is Fellow of the Royal College of Surgeons in Ireland. He is also a Fellow of the Royal College of Surgeons of Edinburgh in the UK and the College of Surgeons of East, Central, and Southern Africa, COSECSA. So over the years, Dr. Simutowe has held significant positions, including serving as the medical superintendent of Kasama General Hospital and the provincial health director for Northern Province, Zambia. His clinical expertise spans across the managing multiple trauma patients, general surgical conditions, orthopedic surgery, urology, and obstetrics and gynecology. Dr. Simutowe's commitment to education is evident through his past involvement in teaching at various institutions and his contributions to the College of Surgeons of East, Central, and Southern Africa, COSECSA. He has also played a pivotal role as an examiner, contributing to the University of Zambia and the School of Medicine for Copperbelt University. Currently, Dr. Simutowe serves as a consultant surgeon at Luanshya, I hope I pronounced that right, Copper Mines, PLC, Zambia, where he manages a wide array of surgical conditions for the mine's employees and registered members. He has been providing bloodless medicine and surgery services since 1989. And as he plans for his retirement for formal employment, he has started a family private practice providing bloodless medical services. Certainly some great achievements, Dr. Simutowe, and we're so glad that you can join us today. So I'd like to present this morning his talk again, Minimizing Blood Loss in Cancer Surgery for Better Outcomes. Dr. Simutowe.
Thank you very much. Let me just share my screen. So we'll be discussing minimizing blood loss in cancer surgery. And just go backwards a bit. Thank you. So in this topic, we see that approximately 313 million surgical procedures are done worldwide each year. And in recent estimates show that 4.2 million people die within 30 days of surgery. This accounts for about 7.7% of all deaths globally. And estimates of post-operative complications and morbidity are even higher. Perioperative bleeding remains a major risk factor after surgery. This was in a paper which was presented by Mr. Shah from Oxford University in UK in 2020. Benign growths or lumps which develop in the body are usually well defined in the edges and hence are easier to remove during surgery. Whilst cancer growths or lumps, on the other hand, are normally ill-defined on the edges, and they tend to be glued to nearby structures and even directly infiltrate these structures. Therefore, surgery in cancerous growths is associated with increased bleeding. In the earlier presentations this week, it has been shown that most patients with cancer are anemic and have other associated morbidities. We'll see that the use of patient blood management strategies markedly reduces the need for blood transfusions as it focuses on preserving the patient's own blood, and this leads to better outcomes. What is patient blood management? I'm sure we've gone through this definition several times. Okay? It is a patient-centered, systematic, evidence-based approach to improve outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. The focus is on patient safety and empowerment. The PBM has a 3-pillar, 9-head matrix of perioperative patient blood management. Understanding this will really guide on how we can manage patients quite well with minimizing blood loss. In the first pillar, where we need to optimize erythropoiesis, preoperatively, we see that we need to detect and investigate and treat anemia and treat iron deficiency anemia. Early this week, we had a lot of presentations on managing this. In my practice, I always manage patients with iron sucrose and erythropoietin, and they do very well. Still on the first pillar, intraoperatively, we need to schedule the surgical procedures quite well. We need to make sure that their blood is well optimized before we actually start the surgery. Still on the first pillar of optimizing erythropoiesis, we see that even after surgery, during the post-operative period, we still need to continue providing the iron sucrose or erythropoiesis to still continue building on their blood. And we need to be aware of the other drug interactions that the drug that they are receiving. In the second pillar, where we need to minimize blood loss and bleeding, okay? If we go back to the preoperative period, we need to make sure that we had a very good preoperative history, looking at all the other morbidities that needed to be sorted out before actually taking the patient to theater, and to develop a good risk stratification so that we manage the patient quite well. There are those patients who are on anticoagulants. We see which ones need to be stopped and which ones need to be continued. So this is very, very important in managing them. The second pillar in minimizing blood loss and bleeding intraoperatively. I think this is the main focus of our presentation. When we're operating, what do we do to minimize bleeding? A tourniquet has been found to be quite effective, especially in the surgery of the limbs. Okay? It is widely used in limb surgery, and it works very well. In my practice, where I used the tourniquet, I remember about 13 years ago, I had a nephew who had a fungating tumor in his left leg below the knee, quite big. He was in severe pain and foul smelling. He was initially being treated at our biggest hospital in Zambia, but because his hemoglobin was 8, the surgeons refused to operate on him until when they give him blood transfusion, which he refused. Until when I was informed, I called him to my hospital, and using tourniquet, and under ketamine, we proceed to do the amputation, above knee amputation. His hemoglobin came down from 8 to 6.5, but post-operatively, I made sure he received iron sucrase and erythropoietin. And with the time, the HB rose up to 10. Then I referred him to a cancer hospital for chemotherapy. So a tourniquet can work quite well in reducing blood transfusion, in reducing bleeding while surgery, in surgery. The second one is cell salvage. In hospitals which have a cell salvage machine, it works very well. In cell salvage is a method of recovering blood from the surgical field, then taken through a machine for cleaning up, then pushed back to the patient. I'm sure Nigeria is doing so very well with Hemoclear, which they have now. A long time ago, I remember a similar way of cell salvage, more of auto transfusion in the late 80s when I was working in the countryside. We used to have a lot of where malaria was endemic. So young children had a lot of splenomegaly. So they would fall from trees, get a ruptured spleens, and would develop a primitive way of auto transfusion where I would get the blood from the abdomen, you get an empty bag of normal saline, put a gauze on top, pour the blood, the cloth will get in the blood goes to a blood pack, and that will be reinfused. Primitive, but now with advanced methods like Hemoclear, so it is quite working well for those centers which have this. Anesthetic conservation techniques. Anesthetists have had a lot of ways in which they improve to make sure that there is less bleeding during surgery. There is what is called permissive hypotension, which they know very well. There's what is called central neuraxia anesthesia. This is where the anesthetic technique play an important role in minimizing intraoperative blood loss. In central neuraxia blockade, where they blockade the subarachnoid and epidural anesthesia, this results in blockade of preganglionic sympathetic nerves fibers, hence arterial hypotension and reduced peripheral nervous pressures. These result in less arterial and perhaps more noticeable, less venous oozing from the surgical side. The other way they use also is the ventilation strategies. So here they provide positive pressure ventilation with the minimal use of positive and expected pressure, and the lower tidal volumes have been advocated to reduce blood loss as it promotes venous return. So a lot of anesthetic techniques which are being used, which help the surgeon so there is less bleeding in the operating field. Meticulous surgery. I think it is very, very important for surgeons to know the anatomy of the area they are going to operate on. Once you know the anatomy, you know the pathology, you know where the blood vessels are, and you're careful when operating, you can make sure that the bleeding is less. Those who operate in the countryside who are not well experienced, they come across a lot of bleeding because they're not well versed with the anatomy and the pathology. So it's very important for the surgeon to know what he's doing, know the anatomy, know the pathology, develop a very good technique when carrying out surgery, and you can manage patients very well without much bleeding. The other areas are the new developments nowadays in surgery, areas with laparoscopic equipment. They are able to operate very well in a small field, contributing to less bleeding. And the latest advancements now with robotic surgery as well, it is really proving quite well in the centers which have this facility with less bleeding. The other final area are pharmacological agents. Commonly used is tranexamic acid. In my practice, I think in most of bigger operations, I always use tranexamic acid. In obstetrics, I always use tranexamic acid. It's cheap and it's affordable, and it's quite well used. There are other drugs which are also on the market which can be used as well. The second pillar also, during the post-operative period, we need to have this vigilance in monitoring bleeding. always reviewing the patient. Make sure the patient's temperature is within normal range, and manage the anticoagulation in case there are some that you continued. We need to treat infection, make sure there's no infection by closely monitoring the patient quite well. In the third pillar, to harness and optimize physiological reserve of anemia. Here, the anesthetic will help us a lot during the pre-operative period, making sure that the patient has enough, the circulation is okay, the blood pressure is okay, the fluid management is okay, patient is not dehydrated. It's very important to make sure that the physiological status is actually quite well. Okay. And then we need to formulate specific, patient-specific plans to minimize in the plan that there's no blood loss post-operatively as well. Third pillar, look at also intraoperatively. Okay. The anesthetic will make sure that they are optimizing the cardiac output, monitoring the ventilation very well, and of course, a restrictive filtration threshold by managing the blood volume very well, and with all the parameters put in place, one can make sure that the patient does not bleed much. During also post-operative period, the third pillar in harnessing and optimizing physiological reserve of anemia. Okay, just optimizing the anemia reserve. Okay, and minimizing oxygen consumption and avoiding unnecessary phlebotomy on the patient. The clinical practice points, we say that a multimodal strategy should be implemented to minimize bleeding. A good teamwork. In the operating theater, it is really important that the surgeon, before operating, work as a team. Let the assistant know what the surgeon is going to be doing. Let the scrub nurse know what the surgeon is going to be doing. Let the anesthetist know what the surgeon is going to be doing. Even the runner in the operating theater, if there is this good teamwork and well coordinated, you can actually enjoy the surgery, and there will be less bleeding because people will know what they're doing and assist each other in every step. It's very important to have a good preoperative assessment with review and management of the preoperative anemia, so that when the patient is going to theater, everything should be in place, and then things will be well. And again, lastly, a close collaboration between the anesthetist, the surgeons, theater nurses, the lab as well, getting the full results, hematological results before you go to theater. I remember a long time ago, sometimes when operating, if we don't have doctor anesthetist, we have clinical anesthetist. So sometimes when you're operating, your eye is on the patient monitor. Your eye is halfway checking the blood pressure. If it's low, you ask the anesthetist, what is happening here? But with a good team, you find that you focus on the patient more. You know that the anesthetist is taking care of the patient quite well. So a good team is very, very important in managing this. What have we learned so far? The potential for major intraoperative blood loss remains a key concern for surgeons and anesthetists. Strategies to mitigate this, such as the identification and the management of anemia in patients, are very important. And these can be implemented early in the pre-operative phase. It is very important to adequately prepare the patient before taken to theater. During surgery, meticulous surgical techniques and local hemostasis are fundamental measures in the control of bleeding. Cell salvage is variable if present. So I think the surgeon's expertise is very, very important. And I think in our settings, we find that most of the doctors who carry out surgery are really not qualified surgeons. general doctors who have been sent work in the countryside and do all these operations, and definitely take a lot of bleeding. So we need for cancer surgery, it needs to be reserved to properly qualified surgeons, properly trained, and who can make a good team to carry out these operations. Then the bleeding can be reduced. Tranexamic acid should be key, really, in most of the operations. And I haven't had any major difficulties with tranexamic acid. It's cheap, it's affordable. So I think all these things are important. Additional anesthetic techniques are important. So we need the nurse support or the anesthetists in our surgery. They do very well with the patient comfortable. You are sure that the anesthetic taking care of all the other parameters. The surgeon can concentrate on the surgery and do very well. So this is my presentation on how we can minimize the bleeding in cancer surgery. And I'm sure there's a lot more we can discuss during Q&A. Thank you very much.